Good morning and welcome to this joint briefing between the House and Senate. We have the Senate Education, Energy, and Environment Committee with our Education Subcommittee led by Chair Mary Washington. We have the House Health and Government Operations Committee and the Public Health and Minority Health Disparities Subcommittee, which is chaired by myself, Delegate Heather Bagnall, and the Appropriations Committee, Education and Economic Development Subcommittee, chaired by Chair Stephanie Smith, and Health and Social Services Subcommittee, chaired by Chair Emily Shetty. Today's briefing is on individuals with chronic conditions in higher education. We have a packed agenda, so we're going to start with the Maryland Higher Education Commission and Maryland Department of Health, and then we will hear from advocates for young adults with chronic conditions. So at this time, I would like to start our briefing with Emily Dow, Assistant Secretary for Academic Affairs with MHEC, Chetan Joshi, who is the Director of Counseling Center and Special Assistant to Senior Associate Vice President of Student Affairs, University of Maryland College Park, Jennifer Howes, Chief Mental Health Director, Johns Hopkins University, Patience Ekocha, Associate Medical Director for Morgan State University, Marcia Weiderfeld, Director of Disabilities and Accessibility Services, Loyola University, and Dr. Nilesh Kalyanaraman, Deputy Secretary for Public Health Services for the Maryland Department of Health. If the MHEC, if you would like to go ahead and start.
Great, thank you. Good morning, chairs and committee members. I am Dr. Emily Dow, and I serve as the Assistant Secretary for Academic Programs at the Maryland Higher Education Commission. Secretary Rye is unfortunately unable to join us today, but he sends his greetings and appreciation for your leadership. On behalf of Secretary Rye, we appreciate the opportunity to join this briefing regarding the report on students with chronic health conditions that was submitted to the General Assembly in 2021. The report included recommendations on enhancing and continuing data collection on students with chronic health conditions, eliminating challenges faced by these students, and accommodating the needs of students with chronic health conditions, including resources and programs. The Maryland Higher Education Commission believes that ensuring that every student, regardless of their health challenges, has access to a quality education. This is not just a matter of policy, it is a matter of equity, opportunity, and fundamental fairness. In Maryland, college students navigate the daily challenges of chronic illnesses, from autoimmune diseases and diabetes to long-term effects of COVID-19 and mental health conditions. We recognize that students with chronic health conditions face unique barriers, including the need for flexible attendance policies, access to medical leave, and academic accommodations that allow them to succeed in their studies while managing their health. Maryland's colleges and universities support students with chronic illnesses in a variety of ways, including disability support services. As required by law, colleges offer accommodations such as extended test-taking time, note-taking assistance, and flexibility in attendance to students with appropriate documentation. Second, telehealth and on-campus medical services. Some institutions have expanded student services to include on-campus healthcare access, including mental health counseling. Moreover, some campuses have also expanded services to include telemedicine as a flexible, more accessible option. Third, flexible course options. Online and hybrid courses have improved access for students who cannot always attend in person. Despite these efforts, we do recognize that challenges remain. Many students report difficulty obtaining those accommodations that I just mentioned, that there are inconsistent policies between institutions, and a lack of awareness about their rights under Americans with Disability Act and Section 504 of the Rehabilitation Act. Additionally, financial burdens related to healthcare costs, particularly for out-of-network doctors and practitioners, can make it even harder for students with chronic conditions to persist and graduate. Here with me today are several campus representatives to speak to their efforts in supporting students with chronic health conditions. I have asked them to keep their remarks brief so that we have enough time for either questions or certainly enough time for my colleagues on this briefing. So let me begin by introducing my colleagues from College Park, Dr. Joshi, the director for the Counseling Center and special assistant to the Vice President for Student Affairs, and Dr. Spiro Marinopoulos, our Chief Medical Officer at College Park. Let me turn it over to them.
Thank you, Emily, and thank you for this opportunity to provide this briefing. Here at the University of Maryland, College Park, we provide a lot of mental health services to students who have mental health issues. And most of the work that is done by the Counseling Center is using a medium-term treatment model, given that it's about balancing the demand for services with the availability of resources. And having said that, though, we do have students on our campus who require more longer-term care. They have chronic mental health issues that require more longer-term care. And we work with these students in 2 or 3 different ways to manage their needs. Depending upon an individual student's situation, clinical situation, sometimes there may be cases where we go beyond the medium-term treatment model that we use and provide significantly more individual sessions or treatment as needed. That's one way, that flexibility that we bring to bear. That's one way in which we are able to work with students with chronic mental health conditions. There are other cases where we sometimes have students who have chronic mental health conditions, but may not necessarily have the finances or may have some kind of resource limitations that prevents them from getting care in the community, in which case, again, we are able to work with these students and provide them the flexibility by providing additional treatment as needed to ensure that their clinical needs are met. We work very closely in partnership with Dr. Spiro Marinopoulos and the University Health Center, who are actually able to provide some of the longer-term care, and we are able to provide care through that collaboration as well. And then finally, the Counseling Center over the last 5 years has worked incredibly hard in creating a very strong referral of community providers that we are able to work with. So much so that we have a clear understanding of the community providers' availability, what their insurance coverage, what network they're a part of. And as a result of that, we are able to do very good referrals into and plug some of these students who have chronic mental health conditions and plug them into the care of these community providers. And that's mainly as a summary of how we manage students with chronic mental health conditions. I'll turn it over to Dr. Marinopoulos.
Thank you, Dr. Joshi, and thank you for inviting me today. On behalf of our University Health Center at the University of Maryland, I want to say that we are committed to supporting students with underlying medical conditions. We have a primary care team which offers evaluation and management for these conditions for those students. We recommend, and this is on our website, it's in our communications to all students who enroll at the University of Maryland who have a chronic health condition and wish to do so, to make an appointment to establish care with one of our medical providers. And this will allow our students to have an ongoing relationship with a healthcare provider on campus, and then we will manage their health. In addition to providing continuity primary care, our providers will refer students for consultation with specialists as needed, for tests, etc., and then we'll follow up to ensure that our students are well taken care of. And we do care for a number of chronic health issues. Some examples are asthma, hypertension, diabetes, thyroid disease, other autoimmune diseases, the same as really any primary care practice really in the community. In 2023, we were fortunate to hire a physician from Johns Hopkins, from the faculty, who is board certified in medicine, pediatrics, adolescent medicine, and addiction medicine. And this further enhanced our ability to provide continuity care to our students, including for issues related to substance use. And then we do have a behavioral health department, which provides psychiatric care for students with mental health diagnoses, which are including major depression, generalized anxiety disorder, ADHD, bipolar disorder, and others. And we recently established a primary care behavioral health program within the health center where we co-manage students between psychiatry and primary care. And then I would be remiss if I didn't mention our close collaboration with Dr. Joshi and the Counseling Center, which further enhances the care we provide to those students who have mental health diagnoses. So these are my comments on behalf of the Health Center. Thank you.
Great. Thanks to both of you. Let me turn it over to my colleague at Johns Hopkins, Dr. Jennifer Howes, the Chief Mental Health Director.
Thank you so much for this opportunity to share Johns Hopkins' approach to supporting our 29,000 degree-seeking students across all of our multiple campuses in Baltimore, DC, and abroad. One thing to really highlight here is the multidisciplinary and multidimensional approach that Johns Hopkins University takes to supporting students with chronic health conditions. This involves close collaboration between our clinical services, so physical medicine and mental health, our student disability services, clinical and non-clinical case management, as well as our student affairs partners within each of the academic divisions and schools, as well as academic affairs. All of these resources engage in substantial outreach to students, both as they matriculate and throughout the school year, to ensure that students have awareness of how to access support as they navigate their academic programs and chronic illness, and as they engage in community activities, and for many of our undergraduates, the residential living environment. We've implemented a number of university-wide policies, such as an updated medical leave of absence policy, as well as support for students who need to navigate, a reduced course load pathway in order to successfully complete their program while also living with chronic illness. And there are also a number of student-led affinity and advocacy groups that are active on campus, including our disability student community outreach and a number of others. We recognize that not all students with chronic illness have or identify as having a disability. But our student disability services is really a critical way that our students are able to access accommodations and receive additional support as they navigate their programs. The Division of Student Health and Wellbeing is a university-wide resource that includes primary care, mental health, health promotion, and disability services is also under that umbrella. And we offer a range of different options for folks to access care related to chronic illness, both things like diabetes, asthma, and a number of other chronic health conditions, as well as mental health conditions that may impact their program and their health. We have approximately 8% of students who are degree-seeking students that are affiliated with Student Disability Services, again, recognizing that that's not a full picture of those who might be living with chronic illness. And our services on both the mental health and primary care side are really coordinated. We are considering ourselves an integrated center that works very closely together to make sure that no matter what the chronic illness that a student might be experiencing, we're collaborating closely in their care, as well as with disability services to make sure that they have the relevant accommodations. We offer a range of both telehealth options and in-clinic services, as well as substantial case management services and referral support in the event that someone's chronic health needs kind of exceed the scope of what we're able to provide. We're able to get them connected to specialty care within the community and make sure that they have access to the resources that they need. I know we're short on time, so I will end my comments there, but thank you again for this opportunity.
Great. Thank you. Let me turn to my colleague at Morgan State University, Dr. Patience Ikacha, the Associate Medical Director at Morgan.
Thank you very much, Emily. Dr. Dab, thank you for having us in this conversation. Greetings from Division of Student Affairs, Morgan State University. At Morgan State University, we have done a great job supporting students with chronic illnesses. And we're talking about illnesses like allergies, asthma, diabetes, heart disease, sickle cell, and mental health. You know, sickle cell being an HBCU, we have a lot of sickle cell students. Pre-COVID, we had we developed a team in 2017, I believe, the Behavioral Emergency Assessment Response, which is BEAR. But then post-COVID, we saw that the need for support to the students with chronic illnesses grew enormously, especially with mental illness. So we turned to a care team that we, in response to the students with chronic conditions. The care team intervention was established in 2022 after the meeting that we had in 2021. So the team works with students, faculty, staff, the administrators, community members, area hospitals to facilitate the appropriate delivery of support within and outside the university for students with chronic illness. So our care team comprises of the case manager, who is the leader of this team, the health center, the housing, counseling center, student conduct, which is the Office of Student Rights and Responsibilities, and student disability and support services. So when a student comes in, the case worker is the one that really sees the student first. Supposing the health center addresses this issue and said this student has been in the hospital for a while and has a need to be seen. So the health center receives the students, and the caseworker actually picks up the students. So the referral and the concern refer to case manager to schedule an appointment, and the appointment will involve the collaboration of all the team members. So once the student meets with the case manager to express their needs, the care team works with the students, faculty, staff, administrators, and community members to facilitate the appropriate delivery of resource support both within and outside the university, including the area hospitals. We follow the students up every week, and collaborate with each other and make sure that they get the care that they deserve and they need. We also have these future initiatives of re-entry policy. This is an initiative geared towards students who were hospitalized. The program will make it the most effective and efficient way to transition them from the hospital back to the university. It will also provide equitable support and resources to our students. Thank you very much.
Great, thank you. Finally, let's turn it over to my colleague at Loyola University, Maryland, Marcia Wiedefeld, the Director of Disability and Accessibility Services.
Thanks, Emily. Good morning. I'm Marcia Wiedefeld from Loyola University, Maryland, where I'm Director of Disability and Accessibility Services, otherwise known as DAS. First, thank you, Senator Feldman and Delegate Pena Melnick for requesting this briefing, and thank you to the Joint Committee members for allowing me to describe how Loyola supports students with chronic illnesses. And thanks for my colleagues who are joining me on the call. I want to provide you with a brief background about Loyola. Loyola is a Jesuit Catholic university in northern Baltimore City. One hallmark of a Jesuit education is the development of a student's mind, body, and spirit, which is the perfect foundation for supporting students with chronic health conditions. We have roughly 4,000 undergraduate students and 1,000 graduate students, and most of the undergraduates live in our housing. This means that we must assist students with chronic illnesses in our housing, such as providing a private bathroom to a student who might have a visiting nurse, or modifying a meal plan for a student who has life-threatening food allergies. Most requested supports are academic accommodations, such as a modification of course attendance policies or a modification of course assignment due dates. These two accommodations are time-consuming for DAS, the office I manage, to arrange with faculty, but they are also some of the most important supports for students who have symptoms that can unexpectedly flare up. Loyola, too, has a care team, which is a weekly meeting of representatives from the academic division, the health center, the counseling center, residential life, DAS, and other offices. We come together to discuss students experiencing some difficulty, which can often be linked to a chronic health condition. A case manager decides who is the best person to support the student and if any referral needs to be made on or off campus. In the 30 years that I have been at Loyola, the most significant change I have seen that supports students with chronic health conditions have come from the Office of the Dean of Undergraduate Students. Among other things, the Dean's Office helps students who request to take a medical leave of absence and helps them return to campus. However, the changes that I have seen that are making the biggest difference in the lives of students with chronic health conditions are the ones that look at the university's policies and procedures and modifies them within reason to help keep a student enrolled as well as helping them towards graduation. I appreciate this opportunity to give you a brief understanding of what Loyola does to support students with chronic health conditions. Thanks for your time, and I hope you have a great day.
Thank you. Before I turn my time over to my colleague at the Maryland Department of Health, I'd like to just share my gratitude to my campus colleagues for their remarks. Maryland absolutely has a responsibility to ensure that students with chronic illnesses are not left behind. By strengthening our policies, expanding support services, and fostering an inclusive academic environment highlighted by the remarks of campus representatives just now, we absolutely can empower students to achieve their educational and career goals. Thank you for your attention, and I will turn it over to the Maryland Department of Health for their remarks.
Thank you, and good morning, Chair Bagnall and the other chairs of this joint committee. I'm Nilesh Kalyana-Raman, the Deputy Secretary for Public Health here at the Maryland Department of Health. And I just wanted to share a little bit about the data that we're able to collect and I'll share with you all. We at the Maryland Department of Health rely on the Behavioral Risk Factor Surveillance System. You may have heard of it as BRFIS, not the greatest acronym, but it is data that we use in a variety of settings, including this one, which is an annual survey that collects data on disease, risk factors, behaviors, and demographics for individuals who are 18 years and older. And it's a standardized survey that's developed by the CDC and is conducted all across the United States. It is data that we use to understand the age ranges here, but this survey does not collect whether the participant is a student at a college or university. So we really only have it for the age ranges in which college students typically are represented in that 18 to 25 age band. From 2011 to 2019, this data showed that chronic conditions which were most likely to affect 18 to 25-year-olds were asthma and depression. And most notably, the rate of asthma in 2019 to 2023 was 11.1% amongst this age group compared to 9.5% for those ages 26 and older, so a little higher prevalence. Same thing for depression. We see it's slightly more prevalent in the 18 to 25-year-old group, 22%, compared to those 26 or older, where it's approximately 16%. Other chronic conditions, which we typically see in greater amounts in older ages, are relatively low in this age group. Things like conditions like arthritis are 3%, chronic obstructive pulmonary disease at 1.8%, cardiovascular disease at 1.1%. And as I noted, this is for all people ages 18 to 25, not just for college and university students. And so this data that we have is really just one part of the story of to paint the picture of what's happening. Of course, the colleges and universities have their own data, and the American College Health Association has additional data. But wanted to at least provide this snapshot of what we see in the 18 to 25-year-olds in the state. And so with that, I will turn it back over to, I'm not sure to the chair or to Dr. Dow, but I'll turn it over.
I think that concludes our remarks from Department of Health and Maryland Higher Education Commission. Thank you, Delegate Bagnall.
Thank you very much. And I want to open it up to our members for any questions before we go to the next panel. So I see a hand from Senator Feldman.
Well, thank you. Just a real question, because I've sort of been involved with this issue for a few years since Chair Pena-Melnick and I put in the bill a few years ago, created a task force, et cetera. Back to the university system, just in terms of data collection, I appreciate the Maryland Department of Health doing that data collection. I guess the question for me would be are Hopkins or University of Maryland collecting data in terms of outcomes, whether it's graduation rates, however you want to characterize it, because that seems to was a missing cog when we did the task force, and that it's good that you're doing the services, but then at least in the higher ed context, not quite sure about outcomes or data collection or, that kind of thing, graduation rates, health, et cetera. So maybe that Delegate Bagnall, I'd put that to either Hopkins or University of Maryland system folks.
Thank you, Mr. Chair, and whoever would be most appropriate to answer that question.
I'm happy to share a bit about our approach. One of the challenges when looking at chronic illness and the variety of ways in which that's defined is there's not one particular survey or metric that kind of gets at that. We look at who's affiliated with disability services. We participate in the National College Health Assessment. We do a fair number of surveys internally that also are aligned, like the enrollment survey and a number of other ones. We also look at graduation rates and track those very closely. We have some new opportunities now that we are using a unified electronic health record system to further that effort at looking at outcomes of the impact of our services on things like graduation rates. It's certainly a developing area, and I think looking at how best can we identify students who might be managing chronic illness and follow their pathway through their educational experience and track those outcomes of our interventions and support is a really important issue.
I could.
Mr. Chair, did you have a follow-up?
No, I guess I'd be curious, is that data available to be shared with certain members of the committee? I mean, I appreciate your collecting it. I'd be curious just to know how successful or what the data actually shows. But I obviously, and again, you were speaking on behalf of Hopkins. Does University of Maryland have a similar kind of a data collection effort or tracking outcomes, that type of thing? I'd be curious from University of Maryland system standpoint if they do exactly what we heard from our Hopkins representative here.
So on the mental health side, we do something similar. For all of the services that we provide, we collect two types of outcomes assessment data. One is just general satisfaction with services, but then we also actually administer a clinical scale at each of the sessions that a patient attends. And then we are able to, and that those scales actually are related to various conditions such as generalized anxiety, social anxiety, stuff like that. And then we track their progress on the main issues that they've come in with across the course of the treatment to see if the services that are being provided are actually effective. Similar to what Dr. House has said, being able to look at retention rates, graduation rates for students who go through the counseling center, through the mental health system is an area that is currently under development, and I hope to be able to bring that online in the next few months.
Okay, I may have some follow-up in the future. I'll yield back to you, Chair Bagnall. I see some other questions, so thank you. Thank you very much.
Thank you, Chair Feldman. Delegate Hill.
Thank you, Madam Chair, and thank you, panel. I was looking back at the report from 2021, and what I heard about your data collection and what individual campuses are doing. When I look back at the report, there are specific problems that the students mentioned as being issues. And what I'm trying to get a sense of is not so much what the individual campuses are doing, but how much across all of higher education we have some practices that may not have been uniform back in 2021, but have become. And the students particularly talk about nutritional support at the dining services, making sure they can get that, specialized resources for athletes, and information so they know what their rights and responsibilities are. And then, so I guess I'll start with that. Other than your individual campuses, what's happening across all of our higher education arena to make sure that these nutritional issues, et cetera, are also being addressed and that the students know what's available to them?
And Delegate Hill, is that directed to Emily Dow?
I have no idea. I have no idea who could best answer that question. It just seems like a lot of scattered data, and I'm not understanding how it tells us what's gotten better in the last 4 years.
Thank you, Delegate Hill. And I am going to ask Emily Dow if you would answer that, because I had a very similar question about the continuity of services across our campuses, and also the responsiveness to what was outlined in the report.
Sure, thank you. So we do leave it up to campuses to develop and provide their own independent policies. As you have heard, many of the campuses have very similar procedures. Some of the challenge in creating statewide standards is our campuses have variability in terms of resources and opportunities for students. So for example, talking about nutritional needs, not all campuses necessarily have a centralized dining hall or even a centralized dining hall that is part of a student meal plan. And so creating those statewide policies, that's why we allow institutions to develop policies unique to their own campus and the students that they serve. Similarly, in terms of access to general health resources, again, not all campuses have health centers. Not all campuses necessarily have access to mental health services. Those campuses often coordinate with local resources through local health departments. And so being able to allow the campuses that flexibility to use the resources that they have provides those opportunities. We can certainly work with the campuses to review their existing policies to date, to see what MHEC can do to better support that work.
May I follow up?
Yes, go ahead.
Thank you very much. So am I understanding you to say that MHEC has not, since you're giving them this flexibility, you have not even said we require or we expect every campus to come up with a nutritional support policy that is consistent with their resources, but does address the fact that you've got students with chronic illnesses that need access to? I mean, the plans could be different on all, but are they required to have that as an example? Are they all required to have something, or it's still whatever you feel like you need, you can have?
We do leave it up to the campuses for flexibility. It is not a required policy to have on file.
All right, thank you. I think that's a problem. Thank you.
Thank you, Delegate Hill. Senator Carrozza.
Thank you. And I want to thank the organizers of this briefing. I think this is a very important issue. I know that we've had this before our committee as an issue before, and I'm glad to see that we are spending time on it. I'm jumping ahead a little bit since I may not be able to stay for the entire hearing. And this question would be directed to the university representatives on the line. I saw that in the testimony from Natasha Vagat, the ambassador for the Invisible Wave, who goes into quite some detail on her specific experiences, that she noted that it would have made a difference to have a case manager in her particular case. And I just wanted to ask the representatives from the universities if any of the if they have that type of model in place yet, and if they had any reaction to that model.
All right, and I see a hand from Dr. House. Go ahead.
Yes, thank you. We have both clinical and non-clinical case management resources at JHU. So clinical case management that operates within our mental health and primary care service to help facilitate referrals to specialty care, ensure that folks get connected to those providers and are walked through that process, as well as supporting individuals who are stepping up or down from higher levels of care, such as hospitalization. They work closely with our non-clinical case managers, which operate within our academic divisions that provide a whole host of support, not only for folks with chronic illness, but any student who might be experiencing difficulties that could impede their ability to progress through their program. And those teams work very closely together. That also involves connecting to other resources such as, financial assistance, basic needs, things like that, to support overall, access to these programs.
Senator Carosa, for the sake of time, would it be appropriate to ask the various institutions to respond to the committees in writing as to what their specific case management services are?
That's an excellent point. And when they respond, if they could note that if they have current case managers in other areas, how that would be, how they serve specifically these students with chronic illnesses, and what the coordination is with those already established case managers. Thank you.
Thank you very much, Senator. Delegate Wallach.
Thank you. And thank you for the presentation. In the interest of time, I also don't need a response right now. I did want to pose the question, though, in terms of resource allocation, when you're thinking about addressing the needs of students, how much have you considered to put towards preventative actions in terms of programs and monies versus obviously addressing the acute critical needs that you're seeing? What does that resource allocation look like? And is there best practice associated with that allocation decision? And I'm happy to take that as a follow-up.
Thank you very much, Delegate. And I do want to make sure that we have time for the second panel, so I appreciate that. I'm just going to also ask Emily Dow to circle back with us, because following up on Delegate Hill's point and Chair Feldman's point, we heard some consistency across our universities. We heard case management, we heard care teams, academic accommodations, housing accommodations. What we didn't hear is what kind of guidance MHEC is providing to our universities. What are the best practices in response to that report and in response to the recommendations that were in the report? And also, if all of these services are opt-in, because we did hear a lot about surveys. And I think in order to get to better coordination of services and greater equity across our entire systems, we need some guidance coming from MHEC. So I would ask that you that you work with the Department of Health and with your university systems and create a guidance document on best practices that you can share with the various committees.
We can do that, Delegate, and we can certainly follow up to some specific answers. We can coordinate that as well. But I hear the directive, work on some guidance, figure out best practices, and get that out to campuses. We can do that, certainly.
Thank you very much. And if you could share that with the committees as well, and any of the members who take the opportunity to reach out to you offline as well. I do want to turn our briefing over now to the advocates for young adults with chronic conditions. We have Santi Bhagat, who is the founder and president of the Invisible Wave, Dr. Adobe Ugochukwu, who is a pediatric resident for Children's National Hospital, Johns Hopkins University School of Medicine, and an invisible ambassador for the Invisible Wave, and Natasha Baggett, who is an invisible ambassador for the Invisible Wave. So you have the floor. Thank you.
Hi, I'm Santi Bhagat. Thank you for holding this briefing. Thank you to Senator Feldman and to Delegate Pena-Melnick and to all of you for participating in this. We've been very concerned about this issue, and we started working on this in 2018, actually 2017, when we held internships in colleges. I am a physician mother of a young adult with a chronic condition. That's Natasha. She's going to be speaking in a bit. And I'm the founder of Physician Parent Caregivers, which is a voluntary nonprofit think tank that's committed to social inclusion of the 20 million young Americans who live with chronic conditions. Historically overlooked and ignored, some of them call themselves young invisibles. In 2020, we launched a movement called the Invisible Wave that advocates for their social and economic mobility. Last year, we hosted season 1 of the Invisible Wave podcast, where you can hear some of them telling their stories about their lives. We're in the midst of a global silent crisis that will change the way we see young adult health. A staggering number are growing up with chronic health conditions that are often invisible to the eye. Millennials are the first generation to experience an unprecedented increase in childhood conditions. They're also the first generation to benefit from advances in science and technology that is enabling over 90% to outlive previously fatal conditions like cystic fibrosis, congenital heart disease, and sickle cell disease. This actually is a miracle that the world didn't expect. So as a result, adult medicine, higher education, employers, government, and society at large didn't prepare to receive these young people, which is why we have these problems that we're talking about today. So we have a data expert, and she has, waiting for a publication to be released, and she submitted testimony, Dr. Wisk, and she has found that 1 in 3 young adults has a chronic childhood condition. And I want to point out, and she points this out in her report, that the data that's collected, like through BHH and all these other data sources, changes at age 18. They start looking at the most common adult chronic conditions. They no longer ask questions about cystic fibrosis and sickle cell. So we're actually missing information on this population. But this population exists in every community and every socioeconomic class. So our organization is sort of working on this since 2009. We fully fleshed out the issue, and we have identified some potential solutions. One of them is around this higher education. We have champions in Congress, Senator Chris Van Hollen and Congressman Jamie Raskin, and they've introduced a joint resolution to raise awareness about this population in Congress. In 2020, Senator Van Hollen wrote 2 letters to the CDC asking them to prioritize this population for vaccinations. Last year, he secured an amendment requiring the CDC to provide a report on federal research on this population. Our state and federal champions envision Maryland as leading the nation on this issue. And I will say that since we started talking about this in 2018, I'm really pleased to hear about some of the progress that's happening in Maryland. We'd like to know more about it so we can share it with our advocates, because right now they don't know that this is going on. So the crux of the problem is that these young adults were not expected to be here. So very little was put in place. Our nation makes significant investments in children with chronic conditions, or as our government calls them, children with special healthcare needs. Federal and state governments, the medical community, philanthropy, and schools all have programs for them, but only up to age 18. That framework comes to a grinding halt just when these young adults venture out into the world and differentiate from their parents. To complicate matters, national surveys stop collecting data at age 18, so we have really very little information on their health status, morbidity, mortality, education, work, and quality of life. They literally fall into a black hole. The only people they can turn to are their parents, who find they're helpless. I'm a physician, and I've been working on this for 15 years, and I can attest that we find very little support to help our families figure out what to do. Again, I'll refer to Dr. Wisk's written testimony. She goes into pretty good detail on the biopsychosocial aspects on this population. So the first need these young adults have is young adult chronic care. It's something in between pediatric and adult healthcare, because young adults are in a unique stage of life, and they need someone to explain to them how to manage their health and how to manage their healthcare team. And the pediatric community has been working on this process called healthcare transition, which is the move from pediatric to adult healthcare. But that's pretty much been stymied because of a lack of pickup in adult medicine. And also, like their peers, young invisibles need and want meaningful employment, financial stability, a partner, family, friends, and their own home. Many want a college degree, and that can make a difference in securing insurance, a stable career, and higher wages. Education is also the most important factor in being able to make sound health decisions, which is an undeniable need for this population. So I'm going a little bit into history. In 2018, then Delegate Lieutenant Governor Aruna Miller introduced the first bill on higher education for students with chronic conditions. And at that time, the fiscal policy noted that the University System of Maryland does not have any policies on accommodations specific to students with chronic health conditions. So this is a critical finding. And the main reason is that across most colleges, disability accommodations are presumed to address the academic needs of these young people, but chronic condition needs are a little bit different. Yes, they do definitely need attendance accommodations, but they need more than that also. So the chronic conditions are episodic and unpredictable. That means they're not the same day in and day out. And we do know it's difficult for professors to accommodate, but we can't imagine how difficult it is for young invisibles when they find colleges are not supporting them and they have to basically plead for support. And this in turn affects their mental health and academic performance, which then cycles back and affects their physical health condition. And just like other students, young adults, young invisibles are in a vulnerable life phase. Many supports could be put in place, some of which I've heard about today, to help them stay on track and graduate. But if they don't, the students suffer, they get poor grades, and they drop out. And I think another aspect which we heard about today from University of Maryland Hopkins is that most college health centers are capable of providing primary care for students with chronic conditions. The Washington Post published an investigative report in 2020 that was prompted by Olivia Paragal's death at the University of Maryland. That report showed that many colleges across the nation have numerous incidents of morbidity and mortality when students go to their centers for acute or chronic conditions. The Maryland Joint Commission report lays out a series of recommendations, including a health case manager. I think they include a basic case manager and a health case manager. At our last bill hearing, Margot Chanella, who directs the Vassar College Health Center, provided testimony, and she talked about a program they have, which is health case management for students with chronic conditions. We spoke to her pretty much in detail in our podcast, and she has an excellent, I think, program which is fledgling that could be the perfect model to help our students optimize their health and succeed in academics. We have a wealth of health and academic institutions here, and we could build on this fledgling program to be a game changer, not just for our state, but for the nation. Bill Gates has pointed out that the US has an extremely high dropout rate. 45% of students drop out or withdraw for a period of time. We need to know how many of this population are students with chronic conditions. They're really not being captured. And college graduates earn as much as 65% more than high school graduates. And this is so important for young invisibles who have exorbitant medical bills and are at very high risk for medical bankruptcy that can ruin their lives. We urge you to consider the impact of students with chronic conditions and young adults with chronic conditions on our state and nation's economy. As of this year, 2025, millennials are supposed to comprise 75% of our workforce. So what does that mean if 1 in 3 has a chronic health condition? Education is inextricably linked to meaningful employment. We need measures to ensure that the 30% who are young invisibles can work, are insured, and stay off of welfare. This is not just about health and educational equity. We have a moral imperative to fully include young invisibles in society and give them the opportunity to be in optimal health, succeed in higher education, and secure meaningful employment. Thank you for hearing me. I'd like to turn this over to our invisible ambassador, Dr. Gushagu.
Yes, hello. Hello, everyone. My name is Dr. Adobe Agachiku. I am a recent graduate of the Johns Hopkins School of Medicine, and I'm currently a pediatrics resident in Washington, D.C. with Children's National Hospital. And so I'm also a lupus patient, so a pediatric lupus patient specifically. I've had systemic lupus since I was 9 years old. And as you can imagine, in the almost 25 years that I've had this disease, it has had a lot of effects in my life. And so I've had to go through elementary school, middle school, high school, college, university, medical school, and now residency with this condition. And so I have a lot of experience when it comes to this issue and this topic of how can we support young people with chronic conditions as they go through education, higher education specifically, and work to join the workforce. And one thing that I've noticed throughout these years of having lupus and working to get accommodations in whichever setting is that there's a lot of inconsistency and there is too much that is kind of just not regulated well. And I really feel that if there were more regulations in place, if there were stricter protocols in place, we wouldn't be kind of losing people and having people fall through the gaps. And so what I mean by that is even trying to get accommodations for board exams, even trying to get accommodations at the university level, in the classroom setting, it just became difficult because there was not anything standardized. And so I really feel that standardization will really help students. And another issue is the lack of awareness that we are not making students know, making sure that they know about these services. And so it's going to be very important for the colleges and the universities, the institutions of higher education, to make sure that students with chronic conditions know at orientation from day one that these services are available, because a lot of students don't know that they can ask for these services. And so for me specifically, I've of course had a lot of prolonged treatment courses, a lot of hospitalizations. I even had to do a leave of absence during medical school because of lupus. And that was because there just really weren't structures in place for someone with a chronic condition in medical school. And there are not even structures in place in residency either. About 3% of physicians identify as having a chronic condition. And so we really need to make it known that these young people with chronic conditions are welcomed in higher education, that they're welcomed in society, that we're not just going to do enough, we're going to do more than enough, because our dreams are big. And so the regulations and the protocols and the accommodations needs to be big as well. So it can't just be sufficient enough to put a degree in my hand and walk me across the stage. It has to be enough to help me accomplish my goals and dreams, because my goals and dreams will benefit society as well. And so this is something that I'm very passionate about, because I really don't want it to be that we go through another quarter century, because that's how long I've had lupus, just about, that we go through another quarter century and nothing has changed. And so we really need to implement these practices right now, today, just to make sure that we're not losing people. Because really what has provided me with fulfillment over these many years, because I'm a very happy person, I have a very fortunate life. And so what has provided me with so much fulfillment is that sense of purpose, that in spite of what I go through with lupus, I'm still able to accomplish what I want to. And so I just want to make sure that everyone is aware of this, because it's a very difficult thing to have to do a leave of absence and to have to say goodbye to your peers and to have to join another class and to meet a whole new group of people and to just try and feel that you belong, because you can't really develop a sense of belonging when you're always having to leave because of your health. And so I feel that this is just a very important issue, a very pressing issue. And so I really thank you all for having this meeting and for forming an audience today for this, and to really just provide all of us young adults with a voice. So thank you so much.
Natasha, you're next.
Thank you. Thank you for this opportunity to provide testimony. I am Natasha Bagad, and an ambassador for the Invisible Wave. I have lived in with epilepsy since I was 8 years old. Like my brothers, friends, and classmates, my life was all about school. I was a gifted and talented student before I got sick. But then I wasn't sure about who I was after I got a chronic condition, which was epilepsy. I went to Montgomery College, community college, and then to American University. I could only take 1 to 3 classes a semester because of my health, and was in college for about almost 10 years. It was very hard for me to go to college for so long, but it was the only path that I knew. I can't tell you how many times I had to ask for an incomplete or medically withdraw from class. And every take semester off from medication changes or hospitalizations, it was very isolated. I never got to live on campus like the other college students. The only support I received at each college was from disability support services. This gave me some accommodations to extend test to time to take, and which was of some help, but nothing really helped with my chronic condition issues. They told me that I had to set up with a meeting with the professor individually, preferably before classes started, which was very hard to do, and explain my situation. Sometimes I felt like I was to plead with them when professors were with me. I did very well. When they didn't, I got very stressed, and I tried to do well in class, but I could not because of my health. This caused me anxiety, and my seizures got worse. Then I would have to drop it in class, course late, and lose money or ask for an incomplete. When I went to campus health centers, they always referred to me to security. I have a medical condition and need health care, but they just wanted my information and made me feel like a security risk. No one ever really cared about my physical or mental health, and there were no support for students like me. They treated me like I was like a liability. I tried to do things on campus, but always felt like an outsider. I'm a second-degree black belt in Taekwondo, and I learned how to persevere. But at one point, when I was on medical leave of absence, and my mother and I drove by American University, I told her that it made me feel very scared because I did not accomplish that goal. It was a turning point. My mom never knew I felt that way, and maybe I didn't either. We had a long conversation, and I finally had to make the very difficult decision to drop out. And I was a junior with 3.5 GPA and had B on the dean's list. My health has been better, but I have been lost about what to do with my life. My entire experience could have been different if I had a case manager to help me navigate academics, health, and campus life. If there were lounges for students with chronic conditions, I would have not felt so isolated. At Invisible Wave, our ambassador team will build a social platform so young invisibles have a place to go and connect with others so they don't feel so alone. Our Invisible Wave ambassadors urge you to create support for students with chronic health conditions so they don't have to give up like I had to do. Thank you very much. Thank you very much. Tasha.
Thank you very much, Ms. Baggett, for sharing your story, and Dr. Ugochukwu and Dr. Baggett for being with us today, and thank you for your perseverance, Ms. Baggett. At this time, I want to open it up to questions from the members. Do we have any questions for this panel?
Hello, Delegate Magdal. Hello, everyone. What I want to say, Senator Mary Washington, I'm chair of the Education Subcommittee in the Senate, and I want to just say on behalf of our committee, just thank you all so much for sharing your challenges with us, we truly do are less for your inability to be able to participate fully. And just know while we are quiet, it does not mean that we are indeed taking this very seriously. The fact that we are all gathered here to hear you, and we've also gathered your institutions so that they may hear you as well as MPAC. So you're very important to us, and it takes a lot of, it's very brave to share your experiences with so many people, and I appreciate you. Thank you. Thank you, Madam.
Thank you very much, Chair Washington. I don't see any other questions, but I want to reiterate the words of the senator. It means a great deal to us to hear these personal stories, and we really appreciate you taking the time to come out and share this with us. We take it very seriously, and our responsibility to ensure that everyone has access to academic excellence and the accommodations that they need to succeed. I know that we have more work to do. I want to thank everyone for your patience. I felt like this was an important conversation to have, so I did not want to rush it, and I appreciate that you all stayed on past the noon hour. Oh, I do have a hand from Delegate Hill.
Quick question. I appreciated MHEC accepting the marching orders. I just wanted to know is there a time expectation? Will we be getting some sense of best practices and guidance within a year, within 6 months, within 3 months? I just like to know what we can expect.
Thank you, Delegate Hill, and you read my mind because I realized I did not request a timeline. Ms. Dow, I saw that you did unmute. What is a realistic expectation? Because we would like to have that report before we adjourn sine die.
You would. Okay, that is helpful to know. If that is your expectation, we will work towards that.
Thank you very much. Thank you, Delegate Hill. With this, we are going to go ahead and conclude the joint briefing with thank you to our Senate partners in Education, Energy, and Environment, and to our House partners in Appropriations. This concludes the briefing on individuals with chronic conditions in higher education. And thank you for continuing this work and to be continued.